So I'd like to welcome our distinguished panel to the stage. Most of them you've already seen, but before I do that, I'd like to introduce our moderator for this session, Dr. Raul Garcia. Dr. Garcia is a member of the American Institute of Dental Public Health Board of Directors and a professor and chair of the Department of Health Policy and Health Services Research at Boston University Henry Goldman School of Dental Medicine. Among his many roles, and he has many, he's a past president of the American Association of Dental Research, AADR, and we appreciate his service to the AIDPH Board of Directors. As I mentioned already, you've had a chance to meet all of our panelists for this session, so I will forego all of the lengthy introductions, but just briefly, we have Dr. Derek Griffith, Dr. Amelie Ramirez, Dr. Lois Cohen, and Dr. Candice Chen here today to talk about race, ethnicity, and culture, and the impact on health and oral health. Dr. Garcia.
Thank you, Dr. Capelli, and thank you all for being here and to the great panel that we've been able to pull together. We're not going to do Slido. At the appropriate point in time, I will welcome each and all of you to either raise your hand or go to a mic and ask your questions in the old-fashioned way, and we'll play it by ear that way. But I just wanted to share my reactions or my sort of take-homes from yesterday's talks and then Dr. Cohen's talk this morning. And as a way to maybe stimulating some thought, I found all the talks very challenging in different ways and very informative. And I guess if there's one way to start this off, it's the way that I start off teaching dental students preventive dentistry. In my first lecture to the second year advanced standing students at BU, these are dentists who've been trained in a foreign country, but come to the States and want to stay in America. And to do that and practice as a dentist, they need a dental degree or 2 years of dental education in an accredited institution here. I also teach the same course, same content to the first year dental students back in the summertime when they start. And my very first lecture slide in preventive dentistry has this line: health is a basic human right. Now, it's not an assertion. I'm not trying to sell them on this idea. I'm simply putting it out there as a true false question for a little quiz that we do electronically. No grading, there's no right answer. And then the related line, which is access to affordable, high-quality health care is a basic human right. And it's interesting to see the proportion of responses, assuming that the responses are not joke responses, that people have sincerely thought about this topic, because I do kind of frame it as a serious question. Well, it was interesting, and I've been doing this for several years now, about 96, 97% of the advanced standing students, about half of them from India, as a matter of fact, will say that they agree with both statements, or that both statements are true in their perspective. When I asked the regular 4-year DMD students, most of whom are US born and US raised, about 85 to 87% will agree. Now, if I were to ask all of you with Slido or some other technique, I would think and hope that 100% of you would agree vigorously with both statements. If you ask, I guess, a cross-section of Americans, my bet, but I don't know the data, is that a majority of Americans would agree with the first statement, perhaps, agree with the second statement, perhaps. But I don't know that even the majority of Americans that would agree with those two statements would be evenly distributed amongst our states. And I'm pretty convinced that it's not a majority of our national legislative leaders who would agree with either of these statements. And I think when we talk about health equity and oral health equity, I think it's these sorts of questions we have to deal with. So I frame it in the context of these are almost like foundational American principles. And it was mentioned yesterday in regards to, I think by Dennis Burrell, in regards to challenges in Texas and getting the legislature to do certain things, how some legislators here in Texas and other places view that government has a limited role or should have a very limited role. And anything that smacks of a right is an entitlement. and entitlement, and we are obligated as citizens to pay for. Don't go there, it seems. And that is something that I don't think we will ever really achieve full health equity and oral health equity until that is now no longer an iffy question, but that the vast majority of people would agree to those statements, and the vast majority of our elected leaders would similarly agree. That's a task for our lifetimes, I think. One of our neighboring states, I come from Massachusetts, New Hampshire, on their license plate, very prominently displayed in very large letters, is their motto, "Live free or die." And I think that sort of encapsulates this very important, basic core philosophical difference about what America's about and what Americans are about and our responsibilities to one another. So I really was struck by Dr. Griffith's presentation yesterday, and it reminded me of my dean at the public health school at BU. I'm at the dental school, but Sandro Galea was the keynote speaker at the APHA meeting last fall. And he focused his talk basically on racism and the impact of racism. And he reminded the audience that slavery, he said it was one of America's original sins. I would say it was the premier and principal original sin of our nation's founding. And it's good to be reminded of that issue. So I guess you call me a lapsed Catholic, perhaps, but I still have that belief that in order to go to the better place afterwards, I really have to be absolved of my sins. But before one can be absolved of one's sins, one first has to acknowledge that one is a sinner, that one has sinned, ask for forgiveness, atone for one's sins. If in fact you believe or agree that slavery is one of America's original sins, again, I'm not quite sure how much progress we're going to make in regards to health equity, never mind oral health equity, until there's a really broad-based belief that in fact was a foundational problem and to this day remains as an unresolved issue. And we have to also remember that, it was the enslavement of human beings, the dehumanization of others for profit, that were foundational to our nation's origins. I mean, they're key. The Sunday New York Times, or maybe it was Monday's New York Times, had an interesting article of a reporter who looked at U.S. history textbooks, high school textbooks, middle school and high school textbooks. And it was fascinating. The same textbook, by the same authors, by the same publisher, had different content state by state, because it's the state's boards of education typically who decide what particular textbooks are approved for purchase and use in their particular state's schools. Wow. Interesting article to see how certain states, I would say, maybe sanitize history to present a certain particular viewpoint. And I don't think it's limited to state boards of education. I think it's, again, an issue that remains highly prevalent in our country, perhaps even regionally varied in important ways. So again, how much progress can we make in dealing with health equity and oral health equity until that is changed and acted upon? So Dr. Griffith also mentioned Du Bois' work, Souls of Black Folk, and the line that the problem of the 20th century is the problem of the color line. Well, it could have been the problem of the 17th century, 18th century, and I think to this day it's the problem of the 21st century in America. But it's important to remember that Du Bois made that statement first, at least recorded first, several years earlier when he spoke in London to the Pan-African Congress, where he used that line to refer to the relationship of non-white peoples across the world and their relationship to their colonial masters. So to our situation here again, I'm not quite sure how much of it is a white-black thing, although it is, but I think framed even more broadly, an issue of power and control and oppression by white colonialists to those non-white peoples all over the world. Du Bois also made the comment later on in the century that he felt that one of the greatest advances was the independence or liberation of India from the British Empire. It did more to advance colored peoples in the world than any other event in the 20th century. So we were asked by Dr. Griffith, how can dental public health professionals address racism and pursue oral health equity? And also, what can I do? What can each of you do? And after my next slide, I'll ask each of our panelists to themselves, maybe give us their advice. From their perspective, what are the 1, 2, or 3 things that we as public health and dental public health professionals and practitioners do in our day jobs or in our private lives or both over the coming months, and why it's important to them that we should do these particular things and not others. So we also heard a lot about what I would call sustainable interventions. Dr. Ramirez gave us some excellent examples of things that actually work, community-informed or community-based research that actually is able to lead to likely successful interventions that empowers communities to act on their behalf. And the challenge is that sustainable? Is it scalable? Is it portable to other groups besides Latinos? Those are challenges of science and research, but also of policy and putting science into action. We also heard about workforce issues from Dr. Chen in regards to, clearly, if our schools of medical and dental education are not buying into a social mission for their graduates, oh my goodness, we're not going to make any progress. By the same token, even if today we had each and every medical school and dental school scoring the top numbers on social mission, it would take 1 or 2 generations to really have a measurable impact, perhaps on the attitudes, beliefs, and practices of the current practicing oral health workforce. So for a long-term solution, it's got to be done. But what do we do perhaps in the short term as well? And we talk a lot about upstream versus downstream interventions, which one should we do? And my answer is yes, do both. Each has its own importance and its own place in particular time. So although we tend to focus much more on downstream interventions, that's okay, we need to. There are problems now that need to be addressed. By the same token, an exclusive or even predominant focus on downstream interventions detracts from those folks that are still going to be born, live, and experience all the problems that we're trying to avoid or ameliorate by the downstream intervention. So to the question, what do we do now in 2020? And maybe I'll turn to Dr. Chen, perhaps? Put her on the spot.
Oh my goodness. Okay. The way that you framed that, I think that there really is this challenge of it is a little bit of everything. But I'm going to add to that the little bit of everything is probably also, from a policy perspective, right-sizing some of the distribution of funding in different places. And after making that kind of response to your statement, let me reflect back on what can we do now. I think that there is a movement inside of health professions and health professions workforce and all of us sitting here to look at ourselves. One of the things that we really see developing is unconscious bias training, right? And we always want to make sure that it's done appropriately and not for an hour on a Friday afternoon when nobody's going to be participating. But it is important to look at ourselves and to look at the biases that we bring into our interactions. And particularly, I think that if we have one-on-one interactions with patients, it's very important that we recognize and look at ourselves. After we recognize and look at ourselves, I think that there is this issue of looking outside of ourselves, and again, we kind of get back to the systems. And I think every one of us works in different organizations, works in different systems. People in this room are from all over the country and work globally as well. And there is a little bit of an issue not any one of us can do everything. But there are things that on a day-to-day basis that we can look at and choose to engage in and choose to engage in these issues of, and I know we started with racism, race, ethnicity, but over the last day and a half, we've talked about, gender was on the room. I don't think we've had a session on gender, but gender. We've talked about people with disabilities. We've talked about LGBTQIA+ populations, and we've talked about global, right? There is so much work to be done out there. I think a good place to start is to look at ourselves and then to look around ourselves and then to choose the things that we can engage and always kind of keep that health equity lens on. Keep this issue of racism or discrimination for whatever group and also I would say, don't beat yourself up because it's impossible to do everything. I think that if you are doing anything, it is important. So.
And so to the point about unconscious bias, I'll agree 100%. It's an issue, it's a problem. It's probably highly prevalent. We don't know exactly how prevalent, and I think it is amenable to interventions that are educational or otherwise. What about the problem of very conscious bias?
Yeah.
The purposeful, planned, overt oppression of individuals because of their race or ethnicity or other characteristic. What do we do about that? But we can deal with that a little bit later, perhaps.
Yeah.
But I think that's effectively a core issue. Lois, so you taught me a new I guess phrase, reciprocal learning.
Yeah.
I'm out of the
I just
loop.
made it up.
Well, if you made it up, my God, what a great coinage! I loved it because it really, I think, to me, frames the value of having a global perspective on issues, including oral health, because of what we can learn in different ways. You gave the example of what we can learn from less resourced communities that we can implement ourselves that can be effective and effectively low cost, which is always a popular thing amongst those who are appropriating resources in our legislators. But also, we can learn about their failures and their successes, and we can modify those to suit our needs. So from your perspective, what should we be doing in 2020 to move this forward as far as promoting equity?
Well, I agree with everything that's been said so far. And with the added emphasis that you mentioned, when I talked about global health, what I really liked about the Institute of Medicine definition particularly was the requirement that you had to have cooperative action to find the solution. No other definition of global health had that aspect. It's collaborative. Even we had started at NIDCR an international collaborative planning grant, knowing that I had gone through the international collaborative studies. The only way you can't have one person do that. Nobody has that kind of information in their head. You have to have multiple disciplines. So it's not only collaborative, interdisciplinary, but then it becomes transformative. Once you sit down with other people and brainstorm, you can collaborate, you can put your economics in, your sociology, your oral epidemiology, your workforce planning in. But after you discuss it enough times, something happens and it's transformative. It's just not an amalgamation of disciplines. It's translating it into something else, something richer, something that wasn't before. In fact, the National Cancer Institute had an initiative for a while on transdisciplinary research. Do you remember that? And I loved it because it really got at that transformative nature. After you collaborate, you get something new. And I think this kind of colloquium is wonderful because it's bringing different groups together, different ideas, professional backgrounds together. And I think something new could come out of that.
Let me turn to Dr. Ramirez. I was struck by her focus on Latinos, and we learned, we didn't already know, that Latinos are not a race. They are an ethnic group by definition. But even within the ethnicity of Latinos, as you all know, I'm sure, there's tremendous variation in actual culture. And it's really the culture that people come from and live in that in many ways affects their health behaviors, health beliefs, health practices, et cetera. So I wanted to ask you to comment on that issue of the variation in Latino communities. I mean, we've got the largest in the US are Mexican Americans, then I believe we have Puerto Ricans, then Dominicans, and then a distant fourth are Cuban Americans. So some sense about Latinos and the challenge in Latino communities and the issue of culture and the variation in Latino communities in regards to advancing health equity.
Sure. Well, thank you for that question. And again, we were one of the first to study and look at these similarities and differences among our population. And the language was the first, major nuances. I mean, just the word for beans, it was frijoles and with Mexican Americans and, different terms that are used for referring to the same word. So we always had to come up with what we called our broadcast Spanish. It was something that, really resonated across.
Telemundo Spanish?
Right. And so that was just, really intriguing for us. But boy, if somebody picked up something we had translated and, quote, in our eyes was broadcast Spanish, they were ready to redline it and circle it and said, oh, no, así no se dice, that's not the way you say it, and kind of, correct this. So then we went, okay, this is the real Spanish version based on Spain, and then in parentheses we had all the other different variations because we never knew where we were going to be. So that was really very important. But even within our different Latino populations, we have class differences as well. Different groups consider themselves a little bit better off than other Latinos. And so this collaboration group that I established, I brought in different researchers representing these different groups to show that we could work together and that within each of our different, and I don't like to use the word subgroups, but within our different population groups, we had also, our different economic and educational scales. So it was really important to be cognizant of that and working with our different communities. And now, just on the way up here, there's going to be a whole forum whether Spanglish should be a new language. Because when I first started with some of our work, only Univision or Telemundo would use our messaging, but I said our youth are no longer speaking Spanish. Our youth are taking a word here and there from their parents and culturizing it, right? And utilizing that in their everyday language. And so now Univision is not like when I struggle, even though I was born in the US, had parents who spoke Spanish and kind of consider myself bilingual, but I still think in English. So when I'm translating for Spanish media, I'll catch myself not saying the right word, and they said, that's okay, you can say it in English, And because they're realizing their audience now is really bilingual. And so I thought that was interesting, whether they should consider Spanglish as a language. But my husband is an educator, and he says what we're seeing in the schools is that because the children are not dominant in one language, it's really difficult for them to move forward. So those are things that, we do need to consider.
Before I open up the question and answer period to the rest of you all, let me just turn to Dr. Griffith and have his input on what we should be doing, what things should we be prioritizing in our actions.
Well, I think, first of all, I think it's having more conversations and discussions like this and being very open about those. I think for me, the biggest thing is to think about what are we actually trying to achieve within the roles that you're playing professionally. There's a lot that we learn sort of in a historical context and a lot that I could, teach you or anybody up here could teach you about, history, context, and we could go through a long litany of terminology and all that kind of stuff. And it may or may not have anything to do with what you do in your professional role, your day-to-day job. And what I would say is we need to get people to focus on what does equity look like and how do you see what equity is in the role that you're playing professionally, and what do we need to give you as tools and supports to help you do that more effectively. The other thing is thinking about how do you, in your context, what kind of equity, if you will, makes the most sense to focus on. We heard a great talk about rural health. That may not be something in the context of where you work that's a major focus, but globally as an organization or as a collection of folks, that's an important thing to think about. Because regardless of where you're entering the conversation, you're still going to need to touch on different populations. So I would think that it's really more thinking of yourselves as sort of links in a chain, that you don't need to do everything, you just need to do your part right and do your part really well and really focus on what equity looks like in your particular job and, commit yourself to growing professionally. Your personal beliefs, I know this is not probably a nice thing to say, I don't really care. Because in this context, it's really not about your personal beliefs. It's about what you're doing professionally. What you think outside of your day-to-day work is not really, in a professional context. In my work as a public health professional, I don't really personally care. What I want to know is, are you doing things that are treating people the same? Are you trying to achieve equitable outcomes in your day-to-day professional job? And that's what this needs to focus on. I think the hard part of a lot of the trainings is they tend to go through personal development to get to professional development, and that may or may not be the way to get to people. And I think those kinds of things can be really difficult. But if we get you focused on, okay, my job as the blah, blah, blah coordinator, as the WIC coordinator, I used to do maternal child health stuff, how are you supposed to sort of administer this nutrition program, and what does that look like? How do you take all these things that we're learning about different populations and apply that to understanding what your job is in that particular role? How do you do that the best and make sure that you're not perpetuating these differential outcomes by race, by rurality versus urbanicity, da 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 da. So I think it's really taking those things into account.
So we have microphones that are floating around. So just raise your hand, and a microphone will be promptly, quickly, all apace brought to you.
Thank you very much for your conversations throughout this day and a half. And for now, I'm curious if we can take this to oral health policy and action there. And let's not beat around the bush. Let's pick an issue like Medicare. Kind of covers all the races. Everyone gets old.
Hopefully.
What can we do? I have a long ways to go before I get there, but I'd like the rest of you to get it ready for me. So, when you think about it from government, from a global perspective, from Latinas, from your perspective, Derek, what would you suggest an anchor or a hammer or a velvet glove that we could use individually and collectively to make a difference? Simple question. I thought I'd start easy.
I can
Jump in.
Well, I was not gonna take a government view on that, but I was gonna share, I guess, a personal reflection from the exercise that we did yesterday, and when we had a patient who was discriminating against a provider. And the question was, what were we going to do? And one of the things that strikes me, and this is happening on a day-to-day basis out in our healthcare, in our communities. And whether it is between us as providers with patients, whether it is us with our colleagues, whether it is us with our neighbors. What struck me is if you hold the line and you tell that patient that that this isn't acceptable, we cannot provide you care, you've stopped the conversation. And it doesn't give us the opportunity, and so many of us know that we're talking in echo chambers. We talk to all the same people. But the very interesting thing about healthcare is that opportunity to talk to people that don't look just like me, that don't come from the same socioeconomic status, and to have a relationship and to build a relationship and to start to set a base for why Medicare should pay or might pay, and why we might pay more taxes to do that, right? I think it's important for us to think about how we open that conversation, and particularly, I guess it's kind of the exercise we did at the beginning where we all kind of moved into our different realms, right? And can we talk across those? And I think just on a very personal level, it's very important. And I think particularly because as any kind of health professional, we have this opportunity to talk across so many groups that we want to make sure that we do that we have a responsibility to do that.
Others wanted to, Lois?
Yeah, one thing that occurs to me globally, of course, is that one of the big challenges that people have been writing about that's facing us, besides climate change and globalization, is aging. There are some other trends, global trends, that are facing all of us. But aging is really a phenomenon that other countries are dealing with. Japan, in particular, is up there as the oldest of the old. And so I will look to them too, but they made change because everybody's aging, even the policymakers. So let's think about them and their needs and their constituents' needs as a way to go, as a step. That's the first thing that hit me, that the whole planet is aging. And as health improves, I mean, although our country longevity is going in the wrong direction, but in other places it's going in the right direction. People are living longer and then increasing the quality of life. And here we get again to the oral health related quality of life and the impacts, developing metrics for that.
I think it's really important to take what you just said, that even the Latino population is considered the younger population in the U.S., but they're aging, and they feel most comfortable going to individuals who look like them. So going back to Dr. Chen's comment, what are we doing about the workforce? But there's also an opportunity, some research that we've done on the use of patient navigators or community health workers to help bridge that. But even then, we did a project in Nevada where we were reaching out to the community. We said, call this number to schedule your appointment with the health department. Well, the person answering the phone was not bilingual. So she would just hang up on them. And we were going like, God, we're working so hard. Why isn't anybody calling to schedule their appointments, Until we talked to one of the participants. She says, well, the lady hung up the phone on me because she didn't know Spanish. So then we gave our community health workers cell phones, to start calling directly into the clinic to help make the appointments. So we need creative strategies out there to help us, make this work. And we can do it. And most of all, but as we go back, is we have to have this sensitive culture to begin with to want to do that.
I think my, excuse me, answer your question, I would kind of riff off of actually something Dr. Cohen said in her remarks this morning when she had kind of the Venn diagram with the three parts, is it would sort of be a combination of what do we know from the data about sort of what do we know and not know? What is the political moment that we need to kind of position ourselves for to pounce, if you will, without being politically correct? When they're going, we know that policy doesn't tend to happen sort of in a linear fashion. It tends to happen when there's a political moment, when something can happen and you can galvanize the right people to actually get things to happen. So, but you need to be poised with the social will, excuse me, and the data to then be prepared to be able to answer that question. But you also need to know the holes in the argument that you have from a data standpoint to be able to do that. So, thinking about what's the economic case for in this case, Medicare. What's the social will? What do people think is the reason that for them it would be important to do this or not do this? So you need to know what people are saying, and then what are the politicians saying? What are kind of their constraints and limitations and opportunities that they're kind of looking for that you can then mobilize? But I think it's bringing together folks who have expertise in those three areas to constantly be in conversation so that you collectively can work together to then have that opportunity to address those issues.
Jay, you had a question. You got the mic.
Yeah, I just wanted to present a different perspective. When we talk about global, I like to talk about local. There was someone I forgot said all politics. Tip O'Neill. Does anyone go that far back? Does anyone go that far back? All politics is local. Well, let's talk about all healthcare is local. In my particular experience, I spent a career with Uncle Sam, spent several years in a community health center, an Indian reservation. I was practicing in an environment that was controlled by non-white people. The board was predominantly non-white. The executive director, a lot of the staff. I was the minority as a, grew up as a suburban white kid with biases. And I think that experience, that local experience of practicing in a non-white minority environment with those kind of values, that put my head straight. Because if you did something or said something that was insensitive, they'll let you know right quick. And I think that does more for getting us straight than education, policies, being in the environment that is right. And so I'm a big proponent of community health centers because that's designed to be a non-racist environment. And I think more of our health providers should at least have an educational experience spending significant time in a community health center. Perhaps mandatory public service in community health centers. Anyway, just a different way of looking at
Thank you
it.
for your comment. Turn to your neighbor, Dr. Sutherland.
Oh, okay, yeah. Thank you. Kind of piggybacking on what was just said, one of the things, I just went to the AAMC, and they had Brian Stevenson, the movie's coming out called Just Mercy.
Oh, I saw.
That is the author of that. And one of the things he emphasized the entire time, and I'll let all of you speak to this, is proximity to get to the level and types of changes that we need. Being proximate to the situation, to the people, to the needs, to practices, all of those different things. Proximity, what does that mean to getting to these inequities and making that shift and transformation?
Anybody want to take a stab?
I might take a stab, if that's
Yeah,
okay. Is that
that's
okay?
okay. That was good.
On both of those comments, and we actually had this discussion a little bit this morning as well in our breakout, is who has power and who should have power. And I think that there's a real movement in recognizing that if you're going to have real change in communities, that the community has to own the
Stake.
all of it, right?
Yeah.
All of it. But if I can translate that a little bit from having been at a little bit of a higher policy level, everybody's not going to be at that level. And in this room, we have people at all different levels. We have people who are in the FQHCs doing the on-the-ground work. We have people who are out of nonprofit community-based organizations that are in schools doing the work. We have people at county government level. We have people at state government level. We have people from foundations. We have people from, well, not me anymore, federal government level. Mm-hmm. And there's an interesting thing about how those ideas translate into how policy is rolled out and how, in a very simple way, for example, when we make grants, right? How we built our grant programs. And did we build our grant programs to respect that or not, right? And I think that there is a budding movement, and it needs to be pushed harder and faster to say, when funders fund, it needs to recognize that the power should be in the hands of the community, right? And that is about, well, I'll give you a very explicit example. One of the programs that I ran out of HRSA was something called the Teaching Health Center GME program. And I showed you some data that showed that Medicare GME actually puts $12.5 billion into teaching hospitals, but to teaching hospitals. if you want training to be in community-based organizations like federally qualified health centers, how does sending all the money to the hospital help that, right? That's a policy level. And the teaching health centers is funded at $126.5 million compared to, 1%. But what it explicitly did was, as a policy, it said, we're going to send the money to the health centers. It has to be the community-based site that comes in for the funding. If a hospital comes in for the funding, they're not eligible, right? So there is this interesting issue of, I completely agree with you, and we have to find ways to trickle that up and make sure that it's reflected in our policies, so our policies support that kind of work, not inhibit it. And I'll get off my pulpit now.
Any other comments or response, Dr. Cohen?
No, that was very good. I mean, NIH in the disparities area has community participative research. So it's trying to get at it. It doesn't always solve. But I also like the comment, both of your comments, proximity and direct experience working in those communities as being transformative. It happened to me too. And I was telling Derek about my first experience out of graduate school, and I came with my husband to NIH. I didn't get hired by NIH right away. It took about 4 or 5 months to get processed, the papers, it still takes that or longer. But they said, go over to Howard University to teach. A professor had illness, and we need you to fill in. And I didn't know what I was getting myself into. It turned out, as I said to Derek, I was given 2 courses in social movements, we called it collective behavior, and 2 in introductory sociology. And it was right then and there, I took over the mentorship of the Student Nonviolent Coordinating Committee, whole period, 1964, June 1964. And my papers got approved for the government. And June 22nd, I'm over there. But on July 1st, they occupied the whole university and shut it down. But I must say that I had an epiphany also, that I was a minority in that situation. And I would look out at the class, all the classes, 4 classes every day that I taught. And I lost my identity. I began to blend with the people I was interacting with. I became one of them. And that changed a lot for me, personally. So I agree with you, and I agree with that comment. I think it's brilliant about proximity. I saw the film. It's really terrific.
If I can just say something that kind of immediately that might identify with each of you is Albert Bandura's theory. There's something called moral disengagement. And I don't know if many of you understand that, but it's easy for us to turn away from a situation than deal with it. And I think that this is proximity that we know each and every day. Some of us may face this situation, but we have to feel comfortable now to speak up for the rights of the individuals that we are trying to help. Because it's just much easier to stay in our little world and where everything is okay and move on. And so that we need to be more confident in saying we can deal with this in our own small way. May not change everything, but if we do that, perhaps more individuals will take that on and try to do something different. So thank you for that question. Appreciate it.
So we're getting close to the end, but I will definitely give Dr. Griffith the last word.
Oh my, we're at the end. So the only thing I want to say kind of in response to both of yours is I would sort of connect to the exercise we just did in the concept of power. So I don't think one of the things that's important in power is to recognize what kind of power you have and where the real power resides. So even though in a local context, it may seem like the people have a lot of power to make different decisions, and you may be in a numerical minority in that context, recognizing that the people above, like in your context when you're talking about Indian Health Service, they didn't set the policies. It was actually the government that set the policies that they were then there to enforce and to then operationalize within that space. So they weren't the ultimate sort of authority over who set those kinds of things. So even with the concept of proximity, understanding where the real power resides and what levers you're really trying to push is really important. So it's kind of like, I mean, the example that I was laughing at in my head was, it's kind of like going to McDonald's. You have a limited number of choices on the menu. It's not like you can just go decide you want to order a steak. So it's like you have to kind of realize that, there are certain things that different ways of thinking about power have a framework for understanding and giving you some latitude within there, but there also are constraints set by the power makers to decide what you can and can't do within that space.
So my boss, Dr. Capelli, has said that in fact, we have time for another question. I will turn to Dr. Evans. Speak his piece.
Yeah, thank you. Thank you so much. And panel, this was a great discussion. As a recovering academic and a recovering administrator as associate dean in a dental school, I want to go back to dental education. We're trying to lead a charge here of change without an army behind us. The potential platoons behind us are not being trained in this regard at all. In fact, the majority would be vastly alarmed by this discussion. If I'm part of that platoon and the local health department wants to open a clinic in my neighborhood and put in a dental operatory, I'm going to be alarmed and I'm going to work with my local society to squelch that idea. If an FQHC opens up in my area, I also am going to be quite repelled by that. I've not been trained in the issue of health inequities, so I'm ignorant of that. And I really don't want those people in my waiting room. I don't have any problem with them, but they may affect my other patients. I really don't want them in my waiting room. So I guess the question, and when you think about how dental education is guided, it's guided by the standards produced by the Commission on Dental Accreditation. And CODA provides, pun intended, only lip service to these discussions. And all you need to do is show that you've got in this course, in this particular curriculum, you've got this lecture that hits upon inequity. And as long as you can show that you use that word, you're going to check that box off. How do we engage dental education so that more providers grow up with this idea, are more open to it, and are more commensurate with this future? Because I'm concerned that we as leaders don't really have followers, and we're trying to create followers. And there are only really a handful of dental schools, and we won't go into this, that take this issue seriously and make a serious commitment to it. But they are going past the CODA standards. They've just decided that that's a thing to do. But it's only a handful of them. And the rest are just checking off the boxes and producing the kinds of platoon participants that I've just described.
Any comments from the panel? You're welcome to pass.
Well, I would say,
No,
Dr.
this
Cohen.
is exactly the situation this La Cascada group faced when we were invited to Colombia. They had a meeting of all their deans and faced the data. You have to show them the data, and they could see it. I mean, it was just more polarized, trying to produce workforce for the rural areas in Colombia where the cartels are and violent and nobody wants to live there. And so it was an epiphany moment for them. And they're still grasping with this problem, but you have to talk about it and raise it at the meeting of their leaders so that they see it. Then they have to change a lot of things. It's not only the regulations, but who they choose to become students. And who are the faculty? Who are the role models? And are the role models in the community or just in the ivory tower, working on simulations of some sort? So, I mean, you have to start somewhere, and we have to start with the leaders.
I'm struck by how powerful that one Venn diagram that you built was with the data, the political will, and that social will, right? Because I think what you're talking about is building social will, and in this case, not to change maybe federal or state policies, but to change private policies and organizational decisions of dental schools and the dental organizations, dental healthcare system. And I think that there's so many different ways and avenues to do that. I think a lot of people have demonstrated some of those things. But actually what I was thinking of is at the very, very beginning, Amelie set some kind of rules for the space, and she said, this is not a safe space, this is a brave space, right? And there's something about taking data and doing analysis that is brave, and I am going to reflect my mentor, who I talked about, that social mission rankings that we did of medical schools. That was, in all honesty, not the most complicated of research projects, but it was brave work. And we still struggle with being kind of labeled the people who did the social mission rankings. In some ways it's good, in some ways it makes some of the work that we do more difficult. But that is one, for the researchers in here to in all ways, not only in dental education, in all ways, is to do brave work, to always be thinking about what it is, why it is that you do work. We don't do work just because, well, some people do, but I think many of us do not do research because we are just trying to answer some random research question, right? We are interested in answering the hard questions that are going to drive change. So that is definitely one way, and then building that social will in various
And
ways.
we need to do that study on dental schools, on social mission, and present that to the deans.
And I think building on your search committees, really sensitizing your search committee in terms of who they're bringing on board, because then you'll have more people to say we need the change to occur.
The only other thing I would just quickly add is I would try to appeal to or figure out what their self-interest would be for getting into this space. So is there something, could you make the case, and it'd have to be a legitimate case, that dental education will essentially be fall by the wayside in some kind of way if you don't start to address these issues. If you're not going to have a patient sort of body, you're not going to be, stay able to have a viable career and profession if you don't start to address these things. So I would try to figure out, is there some kind of way to appeal to, that may not be the nature of the argument, it could be a financial one or something, but is there something that would appeal to their self-interest rather than trying to appeal to just some, moral good or what have you?
Thank you. And on that note, we will close the panel.